Hello, I am Harry Erba, Professor of Medicine and Director of the Leukemia Program at Duke University in Durham, North Carolina. I would like to discuss with you the results of the Phase 3 QuANTUM-First study that has led to the approval in the United States of quizartinib in combination with intensive induction and consolidation chemotherapy followed by continuation treatment for newly diagnosed adult patients with FLT3-mutated acute myeloid leukemia. As you know, based on the results of the RATIFY trial, midostaurin, a first-generation type 1 FLT3 inhibitor, has been used since its approval in the United States, at least since 2017, actually, April 2017. Quizartinib is a second-generation drug that is more potent and more specific for the FLT3 tyrosine kinase than midostaurin. However, being a type 2 inhibitor, it is only active against the FLT3 ITD. In phase 1 studies, quizartinib was shown to have single-agent activity, potentially leading to complete remissions and complete remissions with incomplete count recovery in patients with relapse refractory FLT3 ITD mutated disease. The QuANTUM-First study evaluated the benefit of quizartinib versus placebo in adult patients between the ages of 18 and 75 years with a FLT3 ITD mutation. And these patients were newly diagnosed. Accrual began in September 2016, shortly before the approval of midostaurin in the United States in April of 2017. Most of the accrual came from Europe and other parts of the world, mostly Asia. In this clinical trial, patients could be registered to the study and begin 7+3 induction chemotherapy using cytarabine at 100 or 200 milligrams per meter squared, and daunorubicin or idarubicin, depending on the institutional choice. During the 1 week of chemotherapy, central testing was performed for the FLT3 ITD, and if the ITD was present with a allelic frequency of greater than or equal to 3%, they were then randomized to receive quizartinib 40 milligrams once daily on days 8 through 21, or placebo on the same schedule. For patients achieving complete remission, they could go on to receive up to 4 cycles of high-dose cytarabine. The dose of the cytarabine attenuated in older patients over the age of 60, with either quizartinib 40 milligrams daily for 14 days in sequence or placebo, and then up to 36 4-week cycles of quizartinib or placebo, or 144 weeks. The primary endpoint of the study was overall survival. 40% of our patients in the study were 60 years of age and older, and about half of them had the NPM1 mutation. The primary endpoint of the QuANTUM-First study was achieved with an improvement in overall survival with quizartinib compared to placebo. The hazard ratio was 0.78, or a 22% reduction in the risk of death with quizartinib. The median survival with placebo was 15 months, and with quizartinib, it was 32 months. The benefit of quizartinib was seen even if patients were censored at the time of allogeneic transplant, and the benefit of quizartinib was seen in patients who either did or did not receive an allogeneic stem cell transplant in first remission. The complete response rate was similar in both groups, around 55%. However, there were more CRIs with quizartinib, 17% versus 10%. And the median duration of CR was 3 times longer with quizartinib, 39 months versus 12 months. Relapse-free survival was improved with a hazard ratio of 0.61, or a 39% reduction in the risk of relapse. Placebo median was 13.6 months versus with quizartinib 39.3 months. And at 2 years, 31% of patients had relapsed with quizartinib compared to 43%. We also showed for the first time using a prospective MRD assay, an NGS-based assay for the FLT3 ITD, that patients achieving a CR or a CRI that had a FLT3 ITD allelic ratio of less than 10 to the -4 was associated with an improvement in survival, regardless of which arm of the study they were treated on, quizartinib or placebo. Patients treated with quizartinib achieved a deeper remission with the median allelic ratio in CRC of 0.01% with quizartinib versus 0.03% with placebo. More patients were actually completely negative for the FLT3 ITD by this MRD assay with quizartinib. So we feel the long-term survival benefits conferred by quizartinib in the QuANTUM-First study may in part derive from an early and deep reduction in the FLT3 ITD leukemic burden. Combining quizartinib with intensive chemotherapy and its continuation monotherapy was manageable. There were no new safety signals. However, we do know that quizartinib is associated with QT prolongation. Grade 3 QT prolongation was seen in 2.3% of patients receiving quizartinib versus 0.7% of patients receiving placebo. Patients could actually receive azole antifungal, strong CYP3A4 and other strong CYP3A4 inhibitors with dose reduction of quizartinib in this clinical trial. There is a REMS program, a one-time REMS program that physicians and pharmacists must complete in order to prescribe quizartinib in the United States. However, there was an important safety signal that was seen where the 30 and 60-day mortality was greater with quizartinib than placebo. At 30 days with quizartinib, it was 5.7% mortality versus 3.4% with placebo, 7.5% with quizartinib at 60 days versus 4.9% with placebo. I will be presenting at ASH this year more details regarding the toxicities associated with quizartinib and placebo by age and phase of the study. Now, it should be recognized that the benefit of quizartinib over placebo in this clinical trial, with a 22% reduction in the risk of mortality, is nearly identical to what was seen in the RATIFY trial. However, please remember the RATIFY trial only had patients up to the age of 59 and not 60 and over, and included approximately 30% of patients with a FLT3-TKD mutation that has a more favorable outcome. And in fact, if we look at the benefit of quizartinib versus placebo by age, for patients less than 60 years old, the hazard ratio was in favor of quizartinib, 0.68, or a 32% reduction in the risk of mortality. And at 4 to 5 years, 60% of patients were still alive, compared to 51% in the RATIFY trial with midostaurin. Furthermore, the cumulative incidence of relapse was lower with quizartinib than it was with midostaurin in that trial. On the other hand, there was the hazard ratio for improvement in survival for patients 60 and older was 0.9, with hazard that confidence intervals overlapping 1. And there's appeared to be a greater risk of more early mortality with quizartinib in those older patients. And so I think we still have a lot of work to do in deciding on the best treatment for patients with FLT3 ITD mutated AML who are older and maybe not fit for intensive chemotherapy. So based on the results of the QuANTUM-First study, I think we can make the following conclusions. Midostaurin as a multi-kinase targeted inhibitor should be considered for FLT3-TKD mutated AML patients fit for intensive chemotherapy. But let's remember that the prognosis of FLT3-ITD mutated AML is especially poor. And second generation FLT3 inhibitors have been shown to induce remissions in FLT3-ITD mutated AML as monotherapy, which was not true of midostaurin. The QuANTUM-First study shows that quizartinib has been shown to improve the survival of FLT3-ITD mutated AML patients up to the age of 75 years old when combined with intensive induction consolidation and followed by a maintenance therapy for up to 144 weeks. However, older patients do not tolerate intensive chemotherapy, and quizartinib does add to the myelosuppression seen during induction with intensive chemotherapy. On the other hand, addition of BCL2 and FLT3 inhibitors to hypomethylating agents have not actually shown to improve the survival of FLT3-ITD mutated AML patients either. So further studies are needed to identify older patients who may benefit from potentially curative therapy with quizartinib in combination with intensive therapy, and to mitigate the toxicities of adding myelosuppressive agents to intensive therapy. But also we need to develop regimens that prolong survival with acceptable quality of life in those who are ineligible for intensive chemotherapy. Thank you.